Craig is going to be speaking on transthoracic echo to guide interventions in small infants.
Thank you. I'll wait. While the slides are coming up, I'll just point out that between these two very high-tech, cutting-edge topics, you have me giving a more old-school talk on the use of transthoracic echo to guide interventions in neonates and small infants. Here are my disclosures. So when we talk about the use of transthoracic echo for guiding interventions, here's a partial list of procedures where it can be used. And I'm going to focus on these middle three here: balloon atrial septostomy, PDA occlusion, and ASD closure for the sake of time. So first, balloon atrial septostomy. The description of adding echo to the cath procedure for balloon atrial septostomy has now been over 30 years from the group both in London with Lindsay Allen and Mike Tynan, as well as a group in Washington, D.C., where it was described in '82. And the advantages that were pointed out from the addition of echo included being able to locate the catheter in the cardiac chambers and potentially avoiding trauma. Able to see the balloon as it's being inflated to appropriate size and to assess the size of the ASD that was created. And also resulted in some decrease in procedure time. So a couple of years after that, there's description of doing balloon atrial septostomy at the bedside solely by echocardiographic guidance, and again from the group in London. And that has since spread out and been used in multiple centers. And in fact, we do our balloon atrial septostomies almost exclusively in the NICU. About 10 years ago, there was a report from Dallas about the use of bedside balloon atrial septostomy, looking at safety and effectiveness and cost effectiveness, and they showed that there was improved timeliness to the intervention. There was avoidance of transport to the cath lab and the potential instability when transporting a sick neonate who's hypoxemic and acidotic. There's the obvious lack of radiation exposure and decreased costs that were associated with doing that at the bedside. And as I said, we do that in our center almost exclusively, and I'll show you a series of images how we first help the operator guide the wire across the atrial septum into the left atrium. Then the operator can see the balloon being inflated and up against the atrial septal wall before being pulled through. And then we get an immediate assessment of the effectiveness. And you can see here that we've made the ASD a little bit bigger, but could still be somewhat larger. And if we take the attitude of either go big or go home, we come back with a bigger balloon here. And you can see the ability to really determine the size of the balloon for the size of the chamber before it's pulled across the atrial septum, and then again, looking to show that we have made the ASD unrestricted and larger. So now I'm going to go discuss a little bit about PDA occlusion, and what we're really talking about are babies who are either premature in the NICU or recently graduated from the NICU, and the use of transthoracic echo to guide that occlusion. Neil Wilson and his group published an initial series of 3 cases that were done at the bedside in the NICU on neonates or small infants with these weights. These were done with femoral arterial access and retrograde across the PDA with transthoracic echo guidance. And they were closed either with coil or with an ADO2. And they reported no complications. And here's some images from that publication that showed how they used transthoracic echo to look at the size and shape of the PDA, to look at the coil or ADO device in position, and to assess for any potential obstruction to flow within the aorta or the pulmonary artery. More recently, Evan Zahn, who's be speaking after me on a different topic, but perhaps we'll answer some questions about this if there are any, have described the use of transthoracic echo guided occlusion in their setting at Cedars-Sinai with 6 cases, the initial one at the bedside with a retrograde approach, and then 5 in the cath lab setting, but in a hybrid situation with continued use of transthoracic echo guidance in addition to the fluoroscopy, but the avoidance of contrast and angiography. And so really relying on color and spectral Doppler to evaluate the flow part of the closure, including flow through the PDA, through the device, and the aorta, and then the pulmonary artery. And these were PDAs that were all closed with vascular plug tubes. And there was one malposition with release with the device going down into the aorta, but was successfully repositioned, as you'll see in some of the pictures. So I want to thank Evan and Ruchi Garg, who directs their non-invasive imaging, for providing me this little video clip to show how the transthoracic echo is used to, in this case here you can see the the aortic disc being extruded, and then the evaluation of flow immediately at the bedside, showing no obstruction across the aorta or into the LPA. I'll show this part again about the aortic end of the disc coming out. So there. And also to point out that the use of echo to do all the measurements that are required for choosing device sizes, including the diameter of the PDA and the length. And here's some pictures, some of the images that they had. You can see here the combination of fluoroscopy allows the ability to look at the configuration of the device. Echo shows the position of the device in relation to the aorta and the pulmonary artery. And here are some representative pictures where this was the device that went down into the aorta initially. You can see obstruction to flow within the descending aorta. Here, the device is snared and pulled back successfully into the ductus arteriosus into the appropriate position. So if one is looking at the advantages and disadvantages of bedside versus cath lab closure of the PDA, here's a table that sort of summarizes it. Bedside obviously has the advantage of no transport needed of, again, a potentially unstable baby, obviously no radiation, but has the disadvantages of having to be sure about location of wire tips and catheter tips, maybe incomplete evaluation of device configuration. It's difficult usually has to be done in a retrograde approach. It's difficult to get out the pulmonary artery across the ductus without fluoroscopy. And as you see, potential treatment of embolization can be more of a problem when done at the bedside. And the reverse is then present in the cath lab, the ability to go through the femoral vein. Radiation is limited, which is an advantage, but there's still radiation, so that's a disadvantage. And obviously then fluoroscopy is available and potentially avoiding the use of contrast media. So then going on to atrial septal defect, and while we rarely are doing this in truly small infants, it occasionally needs to be done, certainly in small toddlers, and for that reason wanted to present the potential use of transthoracic echo. I haven't personally been a big fan of it. I think we can use ICE or TTE in most cases, but here was a report from John Moore's group that Rick Carden wrote up regarding the use of exclusively of transthoracic echo in addition to fluoroscopy and angiography. And this was limited to single defects that were relatively centrally placed, at least with adequate rims. And of those, 5 ended up needing to have TE either because of poor transthoracic windows or they had multiple defects. But 66 underwent exclusive transthoracic echo with 56 closures and 9 referrals to surgery. And we, in fact, have done that, and these are pictures that some clips I put together where this was a toddler, small toddler, who had surgery for esophageal atresia, so we didn't want to do transesophageal echo, and our interventionalists, because of prior venous access issues, didn't want to put in a second venous sheath for intracardiac echo. So you can see transthoracic, we can see the defect, we can see the rims. One difficulty, though, is you have to move the probe around a lot to different windows in order to evaluate all of the rims and see the defect from multiple views. And then here you can evaluate the device before release. This is the delivery cable. We can make sure it's not interfering with the mitral valve in this case. And also can watch a wiggle or traction being pulled onto the delivery system to show that the device is in a stable position before release. And then after release, we can obviously we'll see that in this case there was a small residual left to right shunt. And so it certainly can be done, and be done safely. And the use of ASD closure devices in the first or second year of life was described about 5 years ago. Wasn't going to show this so much for the number of patients that were done. I did want to point out, though, that transthoracic echo was used in the smaller infants and after esophageal surgery, and I think those tend to be the ones that would end up getting transthoracic echo. I would point out one of the comments from the article, though, was that in the patient operated for esophageal atresia, the subcostal and transthoracic approach was preferred and gave equally good pictures, albeit the echocardiographer had to sustain awkward and difficult positions. So while it works very well for the interventionalist, it can be a problem for the echocardiographer or the sonographer. And so then looking and then summarizing that, then with transesophageal or ICE, I think the advantages are you will have a good acoustic window and really can keep you really only need a single window for transesophageal within the esophagus or a single venous access for the ICE catheter. Disadvantages, as we pointed out, the rare cases where esophageal pathology may prevent you using transesophageal echo, or the need for additional venous access. There's the cost associated either with general anesthesia or the use of the ICE catheter. Although I think if we're talking about small infants, most of them are going to have some degree of instability and probably going to require anesthesia anyhow. Transthoracic echo obviously allows you to avoid esophageal pathology. You can use moderate sedation. The small patient size, I think, is an unlikely reason. I'll show you that in just a second. As I pointed out, it can be cumbersome. You may have to deal with poor acoustic windows. You have to use multiple windows, so you're moving the probe around a lot. And also, I think it's dysynchronous. It's hard to do continuous monitoring when you have to be out of the field when the fluoroscope is being run. And it's harder with complex ASDs. Talking about the small patient size, I think with the micro mini probe that we have available, we can easily go down below 2 kilos. So I don't really think that that's a reason not to do transesophageal echo purely based on the patient size. And as you can point out, it can get cumbersome. Our guys like a large audience for their caths, and if you're going to try and get in here to do transthoracic echo, you can certainly see that it can get crowded here at the bedside compared to being up at the head where you can do transesophageal echo. So thank you very much.